Okay, so we are starting this seronegative rheumatic disease, and here is a table of comparison between different types. This one is ankylosing spondylitis. This one is psoriatic. This one reactive, average patriotic, and ankylosing, ankylosing and reactive are more common in male, and the uveitis is common in ankylosing, whereas in reactive it's present only in 20% cases. We will just read this. All of these things that have been mentioned in this table are mentioned below. Okay, fine. The first topic is ankylosing spondylitis. It's a chronic inflammatory arthritis, which involves sacroiliac joint and the vertebrae. Okay, and we also have this in this Achilles tendonitis and plantar fasciitis. And the main features of this are back pain. Okay, this is very important point. If there is a back pain in any person for at least 3 months and the onset is below 45 years old, then it can be ankylosing spondylitis. Apart from that, here is also very important point written that if anyone is having aortic regurgitation, then you have to consider AF as your differential. Okay, the features are HLA-B27 positive, inflammatory back pain, arthritis, uveitis, encephalitis, psoriasis, Crohn disease, and elevated CRP will be there. Okay, active and the sacroiliitis on imaging, how we will see it, active or acute inflammation MRI, which is highly suggestive of sacroiliitis associated with AS or definitive radiographic sacroiliitis.
Hello.
Yes, everyone can hear me?
Yes.
Okay, so what's the etiology? It's the inflammation which causes osteopenia, which leads to erosion and then ossification and osteoproliferation. This is the cause of uh, axial and it's more common in male. The ratio is 3:1, and females usually have a milder disease. And they can go undiagnosed also. And then it's more in peripheral arthritis and upper spine spondylitis. Okay. 90 to 95% of patients are HLA-B positive, like patients who are having ankylosing AS, 90 to 95 patients percent people are for HLA-B27 positive. However, in the general population, 9% people are positive for HLA-B27. Okay, now this is the BAT ankylosing spondylitis disease activity index, which is a self-reported scoring system that focuses on fatigue, axial pain, peripheral pain, and morning stiffness. This is the a scoring system in through which we can define this. Now we're talking about the types of pain. So it has been it's classified in two types: mechanical and inflammatory. Inflammatory, as we just read above, which is AS. So now mechanical is that which we can get by any. Okay. Okay, and so if we just go through this chart, so past history is present in mechanical, whereas inflammatory it's also present as well. And family history is not present in mechanical, where it's present in inflammatory. Onset is acute. Here is this, it's not acute. Insidious, and age is 15 to 90. It is usually less than 45. Sleep disturbance, mechanical, there is sleep disturbance, whereas in inflammatory, there is severe pain, which, cause sleep disturbance in the second phase or second half of the night. So you will wake up because of the pain, and morning stiffness is present, which is usually less than 30 minutes in the mechanical, whereas in inflammatory, it's greater than 1 hour. Exercise improves the pain in mechanical, in inflammatory, whereas mechanical, it just worsens the pain. And NSAIDs, it's mechanical, it's respond with the NSAIDs, and in inflammatory, they do not. It doesn't improve that. Radiation of brain is present over here in anatomic like L5 to 5.1, S1, you know, where the nerves are going, and here it is diffuse, and the pain areas are thoracic and buttocks. Sensory and motor symptoms are not involved in inflammatory. Now the clinical presentation, it's the clinical presentation of the AS. So we will be having mild lower back stiffness, morning stiffness, and which will be greater than 1 hour, night pain, alternative buttock pain, and painful joint, sacroiliac joint. And this is the Faber test. Here it is written, which is showing flexion, abduction, and external rotation test. This is a test which is done to, check how much you are having this pain and your movement and all. Okay. And if you can see over here also the normal posture and in a grazing spondylitis, what is the posture? There is an increased occiput to wall distance, means when you will, you know, you will stand straight or wall. When we stand straight, our occiput just hit the wall. And it's with the level of the wall, but here it will not be there. And there is, increased, you can see cervical flexion is increased, increased thoracic artery, there is a curve, and then decreased lumbar lordosis, which means, the curvature inward, it's curved. The normal posture is like this. And this one has been decreased. Okay, spinal restriction will be there. And because of this posture, when you can see that, and there will be decreased range of movements. And yes, thoracic also, because you see the spine is shape has been deteriorated, distorted. Just a second. And there will be decreased chest wall expansion and cervical, also global decrease and often extension first. Postural changes will be there because of all these things. Height will be reduced. There will be, increased kyphosis, cervical flexion, and all. Asymmetrical large joint arthritis will be there, and you'll see, involvement of, tenderness, overtibial tuberosity, and as we just read above, there will be tendonitis, Achilles tendonitis, and everything will be there. Dactylitis will be there as well. Okay, extra-articular manifestation of ophthalmic anterior uveitis, which is common in 25 to 30% of the patients. Amyloidosis, which is late and is rare. IBD will be there. And yes, aortic regurgitation, pericarditis, respiratory apical fibrosis is rare, chordic venous is rare, skin psoriasis. So extra-articular manifestations will be psoriasis, anterior uveitis, and inflammatory bowel disease, and aortitis, aortic regurgitation, pericarditis, and conduction disturbance. So these are the common. Rest are, rest three are rare as well. Okay, so investigation in which we will do the X-ray of the sacroiliac joint. We will see pseudo whitening of the joint due to erosion with joint sclerosis and bony fusion, which will occur later. An X-ray of spine will show squaring of edges, the squaring of edges from erosion and sclerosis on the corners of the vertebrae, and which will cause, and sclerosis on the corners of the vertebral bodies, that is shiny corner sign. So I just searched that shiny corner sign, and it's over here, the shiny corner sign. It's like where the body is repairing that area, you know. I will just read it for you as well. Somewhere. Okay, healing process. Do these inflammatory erosions appear radiologically as reactive sclerosis in the same location, which is known as the shiny corner sign. So it's the healing response toward the inflammatory process, and it appears radiographically as reactive sclerosis in the same location. So this is the, you can see it over here, shiny sign. Here it's more prominent, the arrow one.
Mm-hmm.
So this is the sign here, and uh, and leading to ossification of outer fibers of annulus corpus, bridging. Okay, fine. Okay, fine. You will also see bamboo spine. Here also is also, here is the bamboo. Bamboo is usually the shape is like this, and this is typical sign you will get the bamboo spine. So the main important points here is that we see this shiny corner sign, and then bamboo spine we will see, and squaring of the edges. Will be seen. Okay, and then MRI will access the will find bone marrow edema will be seen on MRI, bone erosions and subchondral bone changes, and best seen on T2, shorter intervention recovery images. And labs, CBC we will do, and we will be having elevated PSR, CRP, ALP, calcium, serum protein electrophoresis, and again this one, HLA-B27. The treatment is divided into two parts: non-pharmacological and pharmacological. Pharmacological, as we just read above, this exercise and this, we will do it. It improves the pain. Um, okay, non-pharmacological prevent fusion from poor posture and disability through exercise, that is swimming, postural and deep breathing exercises, outpatient and smoking cessation. Okay, and pharmacological is NSAID is the first line treatment for peripheral and axial disease. Peripheral, if we see peripheral was this, asymmetric large joint involvements was there, and again axial is the bone is involved, however the spine is involved and everything. Axial and peripheral NSAIDs the first line treatment. If you do not respond to that, then glucocorticoids, topical eye drops, as we can see that uveitis is common in that, and local injections occasionally require systemic steroids prior to other effective treatment. BMARS, only for peripheral arthritis. Sulfasalazine methotrexate we can give. If an inadequate response to two NSAIDs or demands, consider anti-TNF agent or anti-IL interleukin 17 for axial and peripheral involvement. Manage the extra. Okay. Okay. So initially, we will start the treatment with the NSAIDs, and if NSAID and NSAIDs, or we can also give DMARS. But if the condition does not improve with NSAIDs and DMARS, then we will move to anti-TNF agents or anti-interleukin 17 drug group. Okay, now extra, and we will manage the symptomatically, we can manage the extra-articular manifestations, which we were having, which are all, most of them are rare except psoriasis, inflammatory bowel disease, aortitis, aortic regurgitation, pericarditis, and uveitis, for which we are giving glucocorticoids. Okay, and then surgical therapy and hip replacement and vertebral osteotomy. But hip replacement is usually done. Vertebral osteotomy is rare. It's not conducted nowadays commonly. Okay, then extra-articular manifestation is that we have to learn 5S, which is anterior uveitis, apical lung fibrosis, which is again it's rare, but it's 5A for the extraarticular manifestation of AF, and the aortic incompetence, amyloidosis, again, which was in kidney, and it was rare, and autoimmune bowel disease, ulcerative colitis, which means inflammatory bowel disease also, same, because, okay, so the 5S are uveitis,
Uh,
uveitis.
no, I 6 A's in mine. It says 6 A's. Atlanto-axial subluxation is the first one. फिर anterior uveitis और बाकी सारे हैं. And
That's sixth one कौन सा है?
Atlanto-axial subluxation, then anterior uveitis, then apical lung fibrosis, aortic incompetence, amyloidosis, and autoimmune bowel disease. Atlanto-axial subluxation is the first one.
So that's the old edition. I also have that, but
You
she's
have which
she's
one?
reading from the 2023
Oh,
edition.
okay. I have
This
the
is the
20.
recent one, so you might want to cut out the first one.
Oh, okay. Okay.
Yes, because you're going to follow the latest edition.
Yeah, I don't have the 23 one. Yeah.
And the prognosis is spontaneous remissions and relapses are common and can occur at any age. So it can spontaneously relapse also and remit also, and it can happen in any age. Function may be excellent despite spinal deformity. Patient can function properly, but spinal deformity will be there. Favorable prognosis is female, and the age of onset is greater than 40. Means if it's the age is less than 40, then she might have all these kind of symptoms. The prognosis might not be good. She might not respond to the treatment. And I have seen one such case of ankylosing spondylitis. She has been diagnosed at the age of 40, I think. So exact 40 she was diagnosed, because she was having a chronic pain for around one to 1.5 years, and no one was able to diagnose her. Yeah, I'm talking about here in Qatar, and no one was able to diagnose her for the ankylosing spondylitis except when they did some extensive testing. Okay, early onset with hip disease may lead to severe disability and may require arthroplasty. Okay, now it's anterior-hepatic arthritis. Okay, the clinical presentation of MSK is the musculoskeletal manifestation, the setting of ulcerative. I think so. This is nothing too important. We'll just go for here. Okay, fine. Comparing features of spondylitis versus peripheral arthritis, and this HLA-B27 association is present in spondylitis. Gender male is more common. Onset is before IBD, yes, and the typical types of IBD are both ulcerative and Crohn's, and treatment is NSAIDs. And if it's not responding to NSAIDs, then tuberculosis is factor inhibitors, if resistant. And peripheral arthritis, HLA-B27 association is not there, and it's again more common in males. Onset before IBD is no, whereas spondylitis was yes. And parallel IBD course, yes. Types of this, Crohn's disease, NSAIDs, DMARDs, we can give, and tuberculosis if resistant. Okay, have anyone read this from the gastro chapter or something? If anyone want to shed any light on this topic, enteropathic arthritis. Or MSK, what I know is this musculoskeleton. If it stands for something else, then let me know as well. Okay, we are just going through this. Also, known arthritic musculoskeletal manifestation can occur secondary to steroid treatment of bowel inflammation, arthralgia, myalgia, and osteoporosis. We just read yesterday also that there are many side effects of steroids. So, apart from that, myalgia is muscle pain, and arthralgia is bone pain, body pain, and muscle pain, and osteoporosis can occur because of steroid treatment as well, because of that. And this the presentation is ulcerative colitis and Crohn's disease. Peripheral arthritis, which is large joint and they are symmetrical. Okay. Now, psoriatic arthritis, it's the arthritic inflammation associated with psoriasis. Okay, and etiology, it's unclear, but it might be genetic because of immunologic deficiency or reaction, or it can be environmental, that's bacterial viral infection or trauma. Okay. This was something very confusing and I was unable to understand this. It's written that psoriasis, okay, fine, it affects 1% of the population. Nephropathy in 50% of patients with psoriasis and 50 to 20% patients will develop joint disease before skin lesion appears. This is an important point. I was not confusing this one. It was something else. I just mixed up. Okay, so this one is an important point that 15 to 20% of the patients will develop joint disease before the skin lesion appears. And check hidden areas for psoriatic lesions, that is ear, hairline, umbilicus, genital cleft, and nails. TNF inhibitors are effective treatment for psoriatic arthritis with no important added side effect associated with its short-term use. So TNF inhibitors, are effective for psoriatic arthritis if used for short term without any added side effects. And as this is written that okay, fine, the people will develop joint disease before the skin lesion, but we can check the hidden areas for psoriatic lesion, which are these. Okay. Now the clinical presentation is psoriasis. It's well demarcated erythematous black with silvery scale. Psoriatic nail changes are their potential of okay, and psoriatic nail changes are longitudinal ridges is there, discoloration is there, oil drops, oncolysis, and musculoskeletal 5 general patterns, asymmetric. It's asymmetric, less than 5 small and or large joints are affected. In asymmetric distribution, most common is 70%. Okay, the asymmetric oligoarthritis. It's asymmetric, it's the pattern. Okay, arthritis, so this is differential with nail changes, symmetric polyarthritis similar to rheumatoid. Okay. Sacroiliitis spondylitis, usually older male patients. Arthritis mutilans, destructive and deformity, small joint polyarthritis. Other findings sacroiliitis, morning stiffness for greater than 30%, 30-minute in 50% people. Ophthalmic conjunctivitis and ilitis. Or you can say together anterior ilitis. Cardiac and respiratory, which is the late finding, it's aortic insufficiency or apical lung fibrosis. Okay, they are usually seen late, and apical lung fibrosis was seen in AS as well, and it was rare in that, but in 5 A's of AS, it was mentioned. Extraarticular manifestation and psoriatic, it can be seen apical lung fibrosis, cardiac venous syndrome, and in radiologic, will we see floating syndesmophiles, penicillin cup appearance, and osteolysis and periostitis. Okay, I will just see floating syndesmophiles. Floating syndesmophiles. What's this? Floating syndesmophiles. Okay. Desmophyte, bony growth originating inside a ligament, commonly seen in the ligament of spine, specifically the ligament in the intervertebral joints, leading to fusion of vertebrae. Okay, so okay, osteophyte, see, this is a difference. It's the outer, and it's in the inner one. This one, bony growth inside. This one here it is can be appreciated over here. Yes, it can be seen over here, the arrow one. Okay, and the one is pencil and cup appearance. pencil in cup with deformity, and here it is severe. Okay, it's something like, yeah, well, I can see there is something else, like a mushroom, floating mushroom. Psoriatic disease also, pencil in the cup. Pencil in the cup is the radiological sign indicating deformity where fingers have appearance of a pencil lying in a cup. ये मुझे तो कहीं से pencil in the cup नहीं लग रहा. Okay, radiological sign indicating a deformity where fingers have the appearance of pencil lying in a cup. This sign is classically seen in psoriatic arthritis. And is associated with a severe form of arthritis called arthritis mutilans, which we just read here. Where we read here, just we read this arthritis mutilans, destructive and deforming small joint polyarthritis, destructive and deforming small joint polyarthritis. So small joints can be the joints of our fingers, which is causing us pencil in the cup appearance. The treatment is treat skin lesions with steroid cream, salicylic acid, retinoid acid, and tar and UV light, NSAIDs and or steroids should be given. Okay, should not be sole therapy for greater than 3 months. Okay, NSAIDs with or without steroids can be given, but it should not be given for at least 3 months. It should not be a sole therapy. Means what sole therapy? The steroids should not be the sole therapy, and we have to give
Yeah, should not be given
NSAIDs.
for more. Yeah,
Sorry,
I think it's for NSAIDs. Yeah, your steroids
yes, steroids.
and
Okay.
steroids.
Yes. Okay, DMARDs to minimize the erosive disease. Use early in peripheral joint involvement. Non-biological DMARDs, methotrexate, facility, and electronamide. Biological therapies include anti-TNF agents, anti-L, this and anti-IL-12/23, 17 and 12/23. 17 and 12/23. I think so. Where we read 17. Sorry. We just read it here as the TNF agents. They are giving in psoriatic also, anti-IL-17, and in AS, or now in psoriatic also we are giving anti-IL-17, interleukin 17 we are giving here in addition to NSAIDs, then DMARDs, and then tuberculosis factor, interleukin, and interleukin 12 and 23 is added over here. Now, Casper criteria for PSA. Criteria is evidence of psoriasis, psoriatic nail dystrophy, negative results for rheumatoid factor, dactylitis, and radiological evidence. So radiological evidence is what? Pencil in the case and the floating sign. Description is, and there was one more, australized and periostritis. Was there, okay. Description, current, past, of the file. The evidence is, the criteria is evidence of psoriasis, psoriatic nail changes, negative results for rheumatoid, dactylitis, and radiological evidence. If anyone is having this, then show psoriatic arthritis. Okay. Now it's reactive arthritis. One of the seronegative spondyloarthritis in which patients have peripheral arthritis for greater than 1 month duration, accompanied by one or more extraarticular manifestation that appear shortly after certain infection of GI or GU tract. Okay, after GI or GU tract, any infection, and the patient develops peripheral arthritis for more than 1 month duration, it is reactive arthritis. This term should not be confused with rheumatic fever or viral arthritis. Okay. Clinical triad of reactive arthritis is arthritis, conjunctivitis, and urethritis. Okay. Urethritis, cervicitis, or conjunctivitis or uveitis. Arthritis, conjunctivitis, uveitis, urethritis, and or cervicitis. Onset usually, after the infection of GI or GI tract, which is Shigella, Salmonella, Campylobacter, C. difficile species, Chlamydia, Mycoplasma species. Okay. Okay. Acute clinical onset is onset 1 to 4 weeks post-infection. Okay. The acute onset is after a week or maximum 4 weeks after the infection of GI or GI tract. And last week, 2 months of a recurring spinal involvement persists. Okay. So, okay. The clinical course is like this, that usually starts after a week or a 4 week after, you have a genital GI infection, and it lasts for weeks or months, and it's often reactive, like you just go and come, go, come, go, come, and then spinal involvement will persist. Can't see, can't be, can't climb a tree. Triad of conjunctivitis, urethritis, and arthritis is 99% specific, but 51% sensitive for reactive arthritis. Okay, the triad or conjunctivitis, urethritis, and arthritis is 99% specific. Okay, but only 51% sensitive. Okay, the sensitivity is less. Okay, can't see, can't be, and can't climb. Actually. Again, we are seeing HLA-B27 patients, and axial involvement is more than peripheral involvement. Again, it's more common in male. And HLA-B27 was also seen in psoriasis as well, right? No, not in the psoriasis, but the ankylosing spondylitis. HLA-B27 was seen there as well. Okay, so the clinical presentation will be arthritis, sarcoiditis, dactylitis, iritis, conjunctivitis, keratoderma, skin lesion on palms and soles. Can you just see keratoderma? Keratoderma. Okay, this kind of lesions, it's mentioned. The crusty brown color lesions. So what's with it? Okay, hyperthyroid skin lesions of palm and soles. Okay, it's only seen in palms and soles. Ambulanitis circinata. Oops. So skin condition performing the ring-shaped dermatitis of the glans penis. Or something like this. The ulcers over here.
Small penis ulcers.
Okay. So keratoderma is seen on the skin of palms and soles. Ambulanitis circinata is small, shallow, painless ulcers of glans penis and urethral mucus are diagnostic. These, if if anyone's having this, is diagnostic of our reactive
Reactive.
arthritis. Okay, what is colitis, gastrointestinal, oral ulcer, and diarrhea, genitourinary urethritis, prostatitis, cervicitis, cystitis, and pyuria. Investigation diagnosis is clinical plus laboratory evidence of anterior or concurrent infection occupying genital swab, stool culture, blood work, normocytic, normochromic, and anemia will be there, leukocytosis will be there, serial cultures will be there, serology, HLA-27 positive, and ESR and CRP will be raised. Treatment, antibiotics, NSAIDs, again, NSAIDs, we will give diclofenac for May, indomethacin, And exercise, local therapy, steroid injection, topical steroids for ocular involvement, systemic again corticosteroid injections, DMARDs, and TNF alpha inhibitors for spinal inflammation. Okay, the treatment is antibiotics for non-articular infections. Okay, and like non-articular infections, we will have this any kind of this one. And then NSAIDs, DMARDs, NSAIDs, DMARDs, steroids, and local therapies for the topical steroids is for ocular involvement. And locally wearable we can give injection as well with corticosteroids and TNF alpha inhibitors for spinal inflammation. For disease refractory to NSAIDs and DMARDs. Those who are not responding to NSAIDs and DMARDs will give TNF alpha. Yes. Okay, cis crystal induced arthropathies. Okay, so here it was okay. Treatment corticosteroids in the prognosis is self-limited, typically 3 to 5 months, varies based on pathogen and patient's genetic background. Chronic in 15 to 20% of cases. So now we are going to start crystal induced arthropathies, which is gout and pseudo gout. So this is the comparison. Gender uh, in both male are more prominent. Age, gout is middle-aged males, whereas pseudo gout is elderly. And yes, in gout, it's middle-aged men and post-menopausal women. Pseudo gout is usually elderly. Onset of disease is acute. Pseudo gout is also acute. Crystal type is monosodium urate crystals. And here it is CPVT crystals. Positive, okay, negative, 5 inches. And here it is positive. 5 inches. Distribution is first metacarpal. MTP or MIP it's written. MTP. So the distribution is first metaphyseal joint and also mid-foot, ankle, knee, and polyarticular, whereas in pseudocarpal it's knee, wrist, monoarticular, or polyarticular if chronic. Okay, if it's chronic, then it can be polyarticular, whereas it can be knee, wrist, and monoarticular. And the gout, it is first this one, metaphyseal, classically also mid-foot, ankle, and the knee. Okay, radiology of benign erosions and control calcinosis will be seen over here. And osteoarthritis, knee, wrist, and second and third metacarpal joints. Osteoarthritis in the knee, wrist, and the second and the third metacarpal joints. Treatments for acute is NSAID steroids, and chronic is allopurinol. Whereas here in the gout is NSAIDs and steroids. Okay. So gout, derangement in purine metabolism, resulting in hyperuricemia, monosodium urate crystal deposition in tissues, tophi and synovium, microtophy. Okay, the crystal depositions is in in tissues and synovium. So etiologies, uric acid can be obtained from diet or made enriched by xanthine oxidase, which converts xanthine to uric acid. And excess of uric acid results in hyperuricemia. Uric acid can deposit in the skin, subcutaneous tissue, synovium, and kidney, whereas it can crystallize to form monosodium urate crystals that lead to gout. Non-modifiable risk factors include genetic mutations, male gender, and advanced age. Okay, advanced age, male genders, and postmenopausal middle-aged men. And the modifiable risk factors include diet, which is alcohol, purine-rich foods, just meats and seafoods, fructose, sugar within food, see list, okay. Other risk factors are renal failure, metabolic syndrome, and dehydration. For example, the patient is taking diuretics, then also they are, more prone to gout. There is dehydration, metabolic syndrome, failure to metabolize this, or there is renal failure, which is not excreting uric acid. An acute gout attack may mimic cellulitis. However, joint mobility is usually preserved in cellulitis unless it overlaps a joint. Okay, an acute gout attack can mimic cellulitis. Okay. Now, this table, the food list, drugs, okay, furosemide, aspirin, cyclosporine, thiazide diuretics, foods are salt, seafood, alcohol, liver, and kidney, and turkey. Okay, seafood, alcohol, liver, kidney, and turkey. If these are turkey, if these are the food which we have to avoid, but recipients, and the gout, furosemide, aspirin, cyclosporine, thiazide diuretics. Okay. The clinical presentation, single episode progressing to recurrent episodes of acute inflammatory arthritis. Severe pain, erythema, joint swelling, usually involving lower extremities. Joint mobility may be limited. Attack will subside spontaneously within a week, 5 to 10 days, and may reoccur. Okay. Tophi, urate deposit on cartilage, tendons, bursa, soft tissues, and synovial membranes. Common sites are metatarsal phalangeal, yes, ear helix, olecranon bursae, tendon insertions common in Achilles tendons. Okay. Here, okay, that's not sure of it. Okay, kidney, gout, nephropathy, uric acid nephrolithiasis, which is very common. Okay, investigation, John aspirate, greater than 90% of joint aspirate, shows crystal of monosodium urate, needle shaped if done early in the course of presentation. X-rays may show trophy as soft tissue swelling, bone joints, punched out lesions, erosions with overhanging edge. Okay, may show trophy on X-ray. I will just search it. Okay, this is trophy gout and foot. See, this one, the fishes gout. This. Okay, so what's trophy? There it is. Okay. Okay, this punched out lesions, erosions with overhanging edge. Ultrasound shows double contour sign correlated with hyperuricemia in blood. Okay, American College of Rheumatology guidelines for management of gout. Okay, do we need to do this American or we just go with this one? Or is it the same because it's very blurred over here? Anyone? Okay, we will move from here. And the treatment is NSAIDs, usually high dose, and then taper as symptoms improve. Again, corticosteroids. Okay, and if renal, cardiac, or this disease. Okay, when we'll give, if if we can give this if renal, cardiovascular, GI disease, and or if NSAIDs are contraindicated or failed. If NSAIDs are contraindicated or they are not responding, or the patient is having any renal, cardiovascular, or GI disease, then we give corticosteroids. Otherwise, we will stop it. NSAIDs initially high dose, and then we will taper it down. Colchicine, one, okay, first sign of attack followed by this, later BID until attacks have resolved. Okay. I read somewhere that, in acute flares, we just give this. And it's also written here that, colchicine you can give, when the first sign of attack is seen. And then, you will just give it until the attack has resolved. Now, chronic gout, conservative treatment, it's, avoid the food with high purine content, avoid drugs with hyperuricemic effects, that is pyrazinamide, ethambutol, thiazide, and alcohol. These are for TB also and everything. Okay, additional management of lifestyle factors, limiting alcohol intake, limiting high fructose corn soup because sugary. We just read here that because of sugary also, yes, sugary food, sugar sweetened food, fructose levels, corn syrup, overweight, obese, weight loss is recommended regardless of activity level. Medical anti-hyperuricemic drugs, first line is allopurinol in the chronic, okay? In the acute gout, we will give NSAIDs, the high dose, then we will taper. When the symptoms improve, corticosteroids, NSAID is not responding, and the patient is having renal, cardiovascular, GI disease, and then colchicine on when you is just the attack, okay? And we will give until the attack has resolved. But in chronic, it's allopurinol, and the second line is febuzuzab. Okay, decrease uric acid production by inhibiting xanthine oxidase. Start, okay, then tighter up, okay, propanacid and sulfonylurea barely, okay, fine. It's rarely used. So I don't think so that, the things that are rarely used be given, to learn, but it can be, it's rarely used. So, okay, prophylaxis with low dose steroid, NSAIDs and colchicine should be started with urate lowering therapy. Indications for treatment with anti-hyperuricemic medications include, which is anti-hyperuricemic is allopurinol, not nephrotoxic. And second line is capuzicab, which is when attacks is greater than for 2 years, trophy and bone erosion and arthritis is there. Then we will start anti-uricemic medications. Okay, so again, it's chronic, which is greater than two, attacks per year. Greater than 2 attacks per year. Trophy is there, and bone erosion and arthritis is there. Then we will start anti-hyperuricemic drugs. Okay, pseudo gout is the calcium pyrophosphate dehydrate disease. Joint inflammation caused by calcium pyrophosphate crystal deposition in the connective tissue. Etiology and pathophysiology is acute inflammatory arthritis due to phagocytosis of IgG-coated CPPD crystals. Calcium pyrophosphate dehydrate. Crystals by neutrophils and subsequent release of an inflammatory mediators within joint space. Usually monoarticular, but can be polyarticular. It can usually monoarticular, but can be polyarticular, as we just read here. That pseudo gout distribution. It can be, either knee, wrist, or it's monoarticular, but it can be polyarticular if it's chronic. Okay, inflammatory arthritis due to, okay, fine. Old age, advanced osteoarthritis, neuropathic joints, other associated symptoms, hyperparathyroidism, not symptoms, other conditions, hypothyroidism and hypomagnesemia, hyperphosphatasia, low ALP, diabetes, and hemochromatosis. Risk factors are osteoarthritis, hypothyroidism, hyperparathyroidism, hemochromatosis. Okay. Clinical presentation is, it usually affects the knee, wrist, metacarpopharyngeal joints, hips, shoulder, less likely elbow, ankles, big toe, and spine. Less likely elbow, ankles, big toe, and spine. More likely knee, wrist, MCPs, hips, and shoulder. Okay, asymptomatic crystal deposition. Okay, acute crystal arthritis, self-limited of acute inflammatory arthritis, pseudo osteoarthritis, progressive joint degeneration, sometimes with episodes of acute inflammatory arthritis. Okay, wait. This is the clinical presentation. It affects this is this joint. It can be asymptomatic deposition and can only be, just come to knowledge by the X-rays, or it's acute crystal arthritis, which is self-limited flares of acute inflammatory arthritis resembling gout. Okay, in gout, we are having flares, then we give colchicine and NSAIDs and that, but here the flares are self-limited, and it resembles the gout. That is acute crystal arthritis. And pseudo osteoarthritis, because it also involves knee and the larger joints. Okay, progressive joint degeneration, sometimes with episodes of acute inflammatory arthritis. Okay, and pseudo rheumatoid arthritis, symmetrical polyarticular pattern with morning stiffness and constitutional symptoms, frequently triggered by dehydration, acute renal surgery, or trauma. Okay, so one can think that the patient might be having osteoarthritis or rheumatoid because of the similarity in the features. But in these cases, the triggering factor will be dehydration, acute illness, surgery, or trauma. And when doing the test or this investigations, we will by joint spiration, we might get this crystals. Okay, investigation aspirates to septic arthritis and gout. Okay, and the crystal is present in 60% of the patients. Often only a few crystals positive. Okay, blue and rhomboid shaped crystals. X-rays show chondrocalcinosis in 75% cases, radiodensities and fibrocartilaginous structures, that is knee menisci or linear radiodensities in hyaline articular cartilage. X-ray shows chondrocalcinosis in 75% cases. So chondrocalcinosis is the most common symptom. The X-ray finding, and then the radiodensities in the fibrocartilaginous structures. Radiodensity. So if we just go and X-ray of pseudo gout, let me. In this one, we can see chondrocalcinosis. Okay, so the treatment is acute joint aspiration and steroid injection, cool packs, temporary rest, and protection. Cool packs, steroid injection, and joint aspiration to release the pressure and joint aspiration. Yes, because we have to also rule out septic and gout, and we can just, okay, chronic NSAIDs with gastroprotection and low dose prophylactic colchicine. That is controversial. Okay, the treatment here is joint aspiration, steroid injection, cool packs, temporary rest, and protection. And in the chronic, we give NSAIDs, with the omeprazole or anything gastroprotection, and low dose we will give colchicine, but that is controversial, so we can also get this one. So now we will start the MCQs.